Okay, we're going to get started again. So we're going to give Eli, this is more of a hands-on, more of a workshop of a how-to, and gives us an opportunity to talk more intimately with Eli about what he does and how he does it. I think we can be more interactive, is that right?
I think so.
You're going to present some stuff, but also I think he'd be happy to
be yelled at.
Yeah, and engage. So I'm talking to the microphone because we have some people online. If you missed the other half, I'll just do a brief intro. I think you can see on the screen, Eli Rosenberg is an assistant professor of epidemiology at Emory University. He's also, what did you say, guest lecturer or researcher at CDC, working with their behavioral surveillance program. And he works on multiple cohorts of men who have sex with men in Atlanta, and he works with the PRISM group at Emory, and Patrick Sullivan is part of that group, who was a former CFAR guest who you may remember. Okay, so Eli,
cool.
Go ahead.
Great, thanks. Hi everyone again. So I'm going to kind of go deeper into some of our analyses of self-report and just talk about like lessons learned, what we do, and so it's going to have more of a practical side. And if you want even more like practical implementation questions, we can go there too. So that's what we're doing. So, and then we're really focusing today on issues of self-report. And so I'm going to present some kind of march through kind of several several key variables and that we work with and talk about measuring the accuracy of self-report and what we can do about it. So I'm going to very, very quickly go through a very light overview of some of the data that gets us to this point, which we saw in the last presentation, but it's going to be quick. We're going to focus on three factors: substance use, partnership attributes and risk behaviors, and then awareness of HIV status. Three issues for which we've uncovered a bit of reporting bias. And then I'll talk about dealing with misclassification in our model, which actually I showed a little bit a screenshot of before in the last presentation, and then I'll just have some wrap-up thoughts. But then we can just talk. So as I showed before, this is the zooming in on HIV prevalence of an HIV diagnosis in the southeastern United States, and this at the county level, and the black box area is really the Atlanta metro area, which is about 9 or 15 counties, I think, depending on how the census does it. It's a pretty broad geographic area. But really, these two counties here, DeKalb and Fulton County, and then it's actually Clayton County below it, are really the kind of the urban core of Atlanta where we work and live and conduct our lives. And in that area, we really have quite a high HIV prevalence. And as I said before, Atlanta is uniquely at the intersection of a very large population, high HIV prevalence, a very high concentration of men who have sex with men, and a very high concentration of minority men. And so we're really, in a sense, it's a perfect storm of sorts demographically to have a very large HIV epidemic. And so Atlanta is basically number one or number two on new HIV diagnoses for black MSM, depending how you count it, just because we have a very large population. And then as also I showed earlier that we have an epidemic that's really characterized by high HIV prevalence for black men, and that really the prevalence mounts at a very young age, that really by the mid-20s we see about 45% HIV prevalence among black men of sex with men. And we see that really the rise in HIV prevalence is slower and lower for white MSM across the lifespan. But really for black MSM, the risk accrues very quickly in the 20s. So, yes?
So one of the questions I had just kind of come to my mind is, I know in the Southeast, black women are also have disproportionate high rates of HIV prevalence. What is the overlap between these two groups?
That is a fantastic question. And one that a lot of people on and off have been very interested in looking at. We just actually had a poster on this at Croy, and using a synthesis of NHBS and medical monitoring project data. So this is with my CDC hat. We did a bit of modeling work using the care continuum, the kind of care continuum approach that I showed last time, to look at really among transmissions to women, where are they coming from? And we basically found that about a third of female acquisitions in the US came from MSM, about a third from heterosexuals, about a third from IDU. It was about a three-way split. And that's actually very similar to what the virologic surveillance shows. So CDC has in their case surveillance branch, a virologic, like basically a phylogenetic analysis group that just published a paper showing that 40% of female acquisitions were one step removed from an MSM. If you trace it back and look at the strain that basically you get to MSM diagnosis, MSM acquired case. And so we think that actually there's a pretty significant overlap between the two epidemics.
And so if you look at a chart like this in Atlanta for women, is it pretty similar, the distribution and by age as well as?
That's a fantastic question. No one knows. I don't know. No, we could figure that out. The state has the data. I don't know. Well, the sheer prevalence will be lower because, but I bet.
Disparity and then the age distribution.
The age by race piece, I'm not sure.
The disparities are usually much bigger for women than for men.
Yes, for sure. And so, in fact, there's so much so that when we looked at it by race, it was basically all of these transmissions to women were from black MSM. We don't have the race of the females available to us because the way our analysis was set up, but it's basically along racial lines. I have seen the state, Georgia, from the case surveillance in Georgia, that out of their adolescent acquisitions, an amazing amount of black females are in the surprisingly disproportionate in the adolescent group. That you'd expect that you'd have all these teen MSM, and there's all these black heterosexual teenage women, and it's very surprising. So there's probably a significant overlap. Long answer.
What you said quickly about the transmission, you said at one point you said it was 30 or 40% of transmissions, but then you said all of the transmissions are black?
So we looked at, let's say I said a third of the transmissions to females were among MSM. Among those, that third, it was all black MSM essentially, or large majority were black MSM transmissions. We don't have the race of the female, just because the way that NHBS doesn't ask about race of partners in that way. So we think it's a significant overlap. The important piece and what really to help diffuse a lot of the negative. Basically this idea of bridging causes a lot of complication and a lot of it kicks up a lot of dust and people get very upset about it. I think what's really important is that for MSM, having sex with women is a minority behavior, even for black MSM. But you have to imagine that even if it's a few % of black MSM having sex with females, that's when you condition on a female who's living with HIV, it's a small group, women with HIV, and it happens that a large proportion of their infections come from MSM. Among MSM, a very small number of transmissions are going to females. And so this is not a majority behavior by any means for any group of MSM. It's just that when you reverse the arrow and look at the women, most of their infections just happen to originate from MSM. And I think that's really important and helps diffuse a lot of this business about men on the down low. This is a very, very rare behavior for any racial group. So I presented earlier some meta-analytic results here from Greg Millett. And I just want to focus on this one piece, which was that if you look across the literature, what you basically see for various sexual and substance-using behaviors, levels of reporting that are about lesser or equivalent to that of white MSM. So this graph showed the relative likelihood of reporting whatever behavior, and everything to the right of the dashed line means black men are reporting it more than white MSM. And everything to the left of the dashes means it's something that black men are reporting less. And so across a raft of these individual behaviors, number of sex partners, various sexual positions and condom use and so forth, we see black men reported lesser or equal to. And so we're going to revisit some of this because as I showed, this leads to, if you take this at face value, you get some implausible results in our models. And so I want to just step through this here. And I had shown a causal diagram that showed that if you remove these arrows between race and individual risk behaviors, I focused mostly on these other pieces, biological factors and partner factors, because this is what's indicated by all the data, frankly, from Greg Millett, that there was no connection between race and individual risk behaviors. But I'm going to revisit that today. And I had said that we have a bunch, we've done a whole bunch of studies, and I'm not going to go into the details of all these other than to say that we're going to work on data from Involvement in Man Project, which are, we're a year or two out from completion, and thus we have all these analyses coming forward that I'm talking about. Involvement was a cohort study looking at HIV incidence, and the Man Project was a kind of parallel study that did cross-sectional looks at sexual networks. So they were complementary designs in a sense. One, went deeper into network sampling, but at a single time point versus prospective observation on individual men. And the Involvement study was a prospective study with 2 years of follow-up, essentially at 6-month intervals, except there was a month 3 shorter time point. And we were looking at sexually active black men between 18 and 40. And we recruited 803 men, essentially 50-50, black and white. And the idea was to follow forward these 2 cohorts and understand at multiple levels of observation all the reasons for differential HIV and STI incidence. And what we had found, which is really that this was the plot, the graph earlier on age by race HIV prevalence. We found very, very high prevalence, 44% HIV prevalence for black MSM and 13% for white MSM, which is unfortunately a pretty common picture in many urban areas in the Southeast. And we followed prospectively 562 men who are HIV negative at their baseline visit. So I want to talk about 3 validation studies that we did using data from Involvement and the Man Project. So I'm just going to start here with a quote from that Greg Millett paper. This is Lancet did a series in the summer of 2012 on the state of the MSM epidemic around the world. And so Greg updated his meta-analyses, and that's what the earlier slide was, the forest plot. And basically he's saying here that it could be that some of the differences in risk behaviors were due to a systematic reporting bias, and that black MSM underreport the risk behavior. But racially comparative studies have yet to find differences in reporting of risk behavior. Neither of these 3 really go into, from what I can tell, these papers aren't quite so direct in saying that. And one of them is from like 1989. But the idea is that he's saying, that the fact that the same pattern, less risk, greater infection, is evident across studies with different methods, samples, and regions of the country and time would suggest that systematic underreporting is unlikely, which is fair enough, right? I mean, the fact that we're consistently across settings seeing lesser or equivalent levels of risk would suggest that maybe racial differences in reporting are not so true. Or at least the body of evidence would suggest otherwise. But I'm going to show you, at least in our setting, we were able to observe racial differences, at least in one contained geographic setting in one time span. But there's just been this general dismissal of this as an issue affecting findings. Instead, this is really, when we talk about the race disparities for MSM, this is part of, despite saying this, although black MSM have lower levels of risk, we see this. That's always our first. We always open up with this as an assumption. But the fact is, we have some observations that suggest that there are some systematic differences in reporting in Atlanta, at least. And so this is the narrative. Black MSM report lower equivalent levels of risk behavior compared to white MSM. However, we also have this mounting body of evidence of stigma that affects black MSM. We have a whole parallel research universe dedicated to measuring stigma and what does it mean, and how does it impact access to healthcare and participation in research and all of this stuff around stigma. But we have a real hesitation to actually put these 2 together. Well, what does it mean when we have HIV-related stigma, race stigma, and sexual minority stigma all coalescing in the same population? How might that actually impact our reporting and our assessing? And the answer is it kind of does. And we often out of the gate kind of rule out misclassification because I think it's uncomfortable and it's difficult to measure. And so I'm going to talk about, this is really a slide that I threw up in the last presentation. So we're going to talk about drug use, risk behaviors, and awareness of infection. I'm not going to go into the 4th one, which is actually a paper that we worked on with Pamina. But we really need to understand we need some validity studies. We need to understand why this is going on. And so I'm going to take a different plot here. This is from Greg Millett's 2007 paper where he actually went substance by substance and actually did the same kind of forest plot looking the top is actually all drug use, but then he marches through studies of substances to look at the strength of association, and again, between black and white. And so to the right, again, is something that's reported more so by black MSM relative to white MSM, and the left is the reverse association. And the takeaway is the data is all over the place. That's the takeaway. It is all over the place. And the summary odds ratios are here at the top, showing kind of a null association and a few to the left and one to the right. Every single study is self-report. So the entire state of the literature, at least through 2007, and I believe really mostly, is all self-report. Right. So the question is this it? Is this, so what do we do? Is this the end of the story? And so I'm going to go in depth on one analysis, which I know has been talked about to some extent here, and I figured I would revisit this paper just in some depth. When we look at other, when non-MSM populations have been looked at with urine, hair, and saliva biomarkers, there have been actually demonstrated racial differences in the validity of self-report, just never for MSM, but it has been demonstrated in other contexts. So is this, what's this about? Is it, various social desirability biases? Is it somehow different interpretation of self-report measurement tools by race? What's going on here? And clearly there's a very justifiable mistrust that's differential of the research and medical community. And there's probably also quite legitimate fears of judgment and legal consequences for being a black man in Atlanta telling a bunch of researchers about his drug use. And that fear may be quite differential by race, frankly. So in our study, we did the following. At the baseline visit, and only the baseline visit, we did this. We men gave urine specimens, which we did a 5-drug urine dipstick for these 5 substances. So marijuana, cocaine, opiates, ecstasy, and methamphetamines. So notice that the detection windows of these are short. Marijuana stays in the urine the longest. These are actually the maximum time points, and on some of these, there's a range that they give on the packet, and it's really 2 to 4 days or 1 to 3 days and things like that. But these are the max detection windows. And then in the CASI, we do a web-based survey that men take at laptops at their baseline visit, and we ask them about substance use in the previous year. And so we wanted to line these two up. So I'm going to go back to Epi basics here. We're going to go back to Epi 1. Here's a nice 2x2 table for validity, right? And so whoa. Okay, here we go. So the urine screen we're going to present as truth from the heavens, and self-report is our tool that we're going to use to uncover truth. And so what we want to know is, for example, how many of the urine screen positive folks have also reported positive through self-report, right? And that's called the sensitivity of the self-report. So that's the language that we're doing here. How sensitive is self-report? How many people through urine drug screen are we picked up through the survey, essentially? And that is this ratio, the true positives over the total that urine drug screen positive. The other quantity is the specificity, which we can't do. Just talking with Pamina about this. The specificity we can't compute because there's a mismatch in the detection windows. Somebody drug screens negative, but says yeah, I did cocaine. Well, is it because of are they falsifying that, or is it just they did cocaine more than 5 days ago? And so that upper right corner we can't get, and so we can't get specificity. For this analysis, we said that's okay. We're mostly concerned about the other situation, which is underreporting in the underreporting in the face of some truth, which is the urine drug screen. And so we were less concerned about the false positive self-reporting issues here. Obviously, we still might want this information as well, but we really restricted what we did to more of a sensitivity piece. How many urine drug screens were people who were positive by drug screen were reporting in the survey? And so here's some results out of that paper. So this is highlighting self-reported marijuana use among our black and our white participants. And then this is the ratio of positivity, essentially. And so 29% of black MSM are reporting marijuana use versus 43% in the previous year. And that basically gives you the relative reporting of 0.68. So 32% less usage among black men relative to white men. Now, using urine detection, so this is marijuana, this is basically urine detection in the last month, the association completely flips, and you get a higher level of usage in our black men relative to our white men. So you get 40 or 39% higher usage when you look at through urine. So a complete reversal of association when you do a urine screen versus self-report. Yes?
But it looks to me like your self-report and urine detected marijuana are the same guys.
Nope. That enter sensitivity. It's actually different guys. So it's not all the same guys. So 64% of the urine drug fellows are, the sensitivity down here would say that 64%, so this is over 120, there must have been a data thing, but out of essentially these guys in the numerator that were positive on urine, only 64% of them were in the self-reported guy that told us through self-report. There's actually, so right, it looks like it should be the same guys here and here, but it's actually only two-thirds overlap between the two. And again, part of the confusion is that the windows of recall are slightly different, so it's a little bit of mental gymnastics. But when we see this, we see the same pattern for cocaine usage. So 10% by self-report versus 25%, and so 58% less usage for black men relative to white men, whereas we had higher positivity in the urine. Now notice these percentages are now much, much lower because of the short detection window. So at any given, so 25% might have used in the previous year, but only 5% in the last few days. So so we have this misalignment of detection window. But again, when we condition on just looking at we take just the folks positive by urine detection and say how many actually self-reported, we see actually that there's much more alignment for the white men, that 84% of men who are positive by self-report, by urine, also self-report positive, whereas only 54% of black MSM were, of those positive by self-report, by urine, were also positive by self-report. So this flipping is because of a differential sensitivity of self-report by race. Yes?
For the self-report, was it for the previous 30 days? Or
just year.
For the year?
It was the year. So we didn't go into the study looking to validate this. So we did the urine detection thing as a side interest. We didn't, the windows, ideally we would have, if we were setting out just to do a validation, so we should have asked for each drug the recall period by the detection window, but we didn't do that. But otherwise we'd have to have you used cocaine in the last 5 days, have you used marijuana in the last 30 days? But this was a standard kind of instrument for 1 year recall.
The other factor that I'm thinking of though is what year was this data collected?
2010 to 14.
Okay. Well, whether or not marijuana is legal, I don't think you have the same laws about it in the state. We have such easy access and different issues around. I think we would probably have a much higher self-report marijuana. So we may have a narrower. Who knows? We should put our data.
So I would say just if we for our new cohort, our NIDA cohort, we did a lot of just substance use focus groups, and I mean everyone just among in the black MSM community, marijuana is ubiquitous.
And you even have medical marijuana.
Yeah, I mean most guys will just say I mean you go out to the club, you're walking around with a blunt, this is just the thing. So I would say once you really start talking to guys, it's very much part of the culture. It's just what comes out on these. But but legally, there's no legal way to get marijuana or. Oh no, not yet. Right. So, but honestly, I mean, I've observed, I've been out recruiting, and the police culture is often very lax around marijuana usage. So, I mean, I've just seen guys smoking right next to the cops. So it's pretty open. I mean, the cops will monitor what goes on in these block parties, and they just stand around. I mean, so anyway, but basically we have this reversal of association. What is interesting that the relative notice that because most of our white men are accurately reporting their usage, the ratio, this is what we were talking about, the ratio between 1 year and 1 month recall suggests something about the frequency, which is kind of interesting, of usage. Yes?
It seems like the same relationship isn't holding up for methamphetamine. Do you not think that that's a part of the story?
I think our data is too sparse for methamphetamine. So I think that's what it, I mean, so it's a good.
Do you have any other data on methamphetamine use in Atlanta?
No, it's so uncommon. We do not have West Coast methamphetamine usage. It's really just uncommon. The word on the street is that meth is going up in Atlanta, but
So low.
it's so low. So we really focus the rest of the paper on marijuana and cocaine because that's where the usage is. Yeah, just two men did with detection, and yeah, it's just low. 10% of the sample? Yeah, well, it's low. Yeah, for our white men, we had higher reported. For the racial comparative, we just didn't have enough black men really using meth. Just wait. We'll wait. So we did some adjusted models as well, and we adjusted for a whole bunch of factors here that we thought were of importance. I want to say that I think the adjusted and the unadjusted, when you're doing stuff like this, the adjusted and the unadjusted are informative because what's a cause and what's an effect is complicated here, right? So arrest history, you can be arrested because you're using substances, and so controlling for things after or downstream in the causal pathway after the things we're studying about is iffy. So we reported both adjusted and unadjusted results, and frankly, it doesn't really matter. And the basic idea here, so this table is looking at what happens to just the prevalence ratio. The other tables were showing the actual levels of usage also. But what happens to the prevalence ratios once you adjust for things and not, and basically this reversal of things from 0.68 to 1.4 holds up. And so here the sensitivity 0.71. This is this is essentially the ratio of the sensitivities. So this is showing, this is a funky thing. This is a ratio of ratios. This is showing that the sensitivity is 29% less for our black men relative to our white men. We're trying to digest a lot of information here. But this is showing the relative sensitivity of self-report by race. So we're showing basically a third less sensitivity of self-report by race in our study across marijuana and cocaine. So obviously the confidence intervals get wide here because this whole analysis is restricted to urine positive people. And so that's a subset of the study that's going to be have screen positive through a urine screen. But basically we're showing so this reversal of fortunes from self-report, and it really holds up. So now what? So now what do we do? So I think clearly we need to we need to replicate this. This is our one study in Atlanta. I think we need to be routinely incorporating these assays in our work and seeing how this holds up and actually just using biomarkers for substance use consistently. I mean, honestly, it's cheap, $5 to $10 a test. I think that is worth having good data for, $5 a test. The cost is going to be dependent on how many drugs you want to screen for. So we used a 5-drug test, which is frankly where they start. They go up to 15 substances. The ones that are most prevalent in Atlanta, you could basically pick up with a 10-drug test. And you be pretty comprehensive. They're usually self-contained. We used a dipstick kind of one where you dip into the urine, but we are now using a fully self-contained cup. So men urinate in the cup, and then they close it, and then it starts cooking the test right away. So that's nice. So it's an easier burden on the lab, obviously, just to look at the cup, and it has a little window, and it shows you what's going on. And those are pretty cheap. So men are willing to do these. I mean, no one has really provided an issue. We routinely obtain and explain NIH certificates of confidentiality. We try to say, your employer, your whoever, the law, the government has no access to this information. You're protected by a certificate of confidentiality. So I'm sure you guys are routinely doing. Yeah. But I think what's clear is to communicate this. We communicate this several points. And I'll show you a screenshot later. We're now in the surveys. We're saying, hey, just so you know, remember, your data is protected in these ways. Like, we're trying to really get more and more out in front of this and try to remind people that it's okay. So I wanted to say, we're doing a new study element, which is a cohort study of just Black MSM 18 to 29, and this is the NIDA supported study, and we're basically looking at it's a very epi-geeky study looking at causal mechanisms to try to understand how exactly substances impart added HIV risk in the Black community, and I just want to. Honestly, the only real point to say here is that we're now doing this at every visit. And so we've routinely, we did this that was our validation study as out of our baseline visit of our old cohort. The study in many ways is similar to involvement, but yet is just among young Black MSM. It has a very large PrEP component, which we could talk for a long time about. It's been really fascinating, the PrEP side of the study, because we have very, very limited PrEP access in Atlanta. This is the first PrEP experience for this community in many ways. But we're now routinely at every follow-up visit doing a 7-drug urine cup, and we're now also doing a cool blood-based marker for heavy alcohol use, which we haven't have any data yet because the kits are like infinitely delayed. But we will have really cool heavy alcohol use, so we'll be able to do this validation work on alcohol as well.
So that's
Yes.
not PEF?
No, that's carbohydrate deficient transparent.
Mm-hmm. He said. Yeah, yeah, exactly. And this is basically heavy consumption in the previous week, basically is what it picks up.
So the
Yep.
other question I have was about this non-prescription drug. It made me think of prescription drugs.
So,
Looked at those at all?
what's that?
Have you looked at the prescription drug use?
So we didn't have it in the previous 5. So oxycodone and similar are.
Did?
No, we didn't have it before. We just had the 5 that we had last time. So I think
Now you've added it.
I want to say like Oxy and PCP are the 2 new ones or something. I forgot what the 2 new ones that we now have in the 7-drug panel are. Yes.
So last time I looked at CDT, it was pretty racially, it had different responses in different racial ethnic groups.
Really?
So it's
Yep.
more sensitive and specific in white populations and less in black. So, so I don't know if they may have like done something against that.
Yep.
But
That's interesting.
A couple of years ago, that was something that was diminishing some interest about this test.
Really? Okay, so that's helpful to know.
Ray Anton in USC can give you background on that. There's
That's helpful. I was following the lead of our core labs at Emory, and they're like, "Oh, you got to use this. This is the rage." And okay, helpful.
good that you have that in kids.
So anyway, so this is just to say that our lessons learned are, we're now routinely incorporating urine drug screens. It's worth the price to get good data. So what about risk behaviors? So this is harder. There's no available biomarkers for sexual behaviors. So I'm going to talk at the end about some work that's been done on this. Let's just say there's none for anal intercourse. There are biomarkers for vaginal intercourse. But we can conduct agreement studies. And so what we did was with our MAN project data, this is our sexual network study, and we did basically a referral sampling project. We actually we linked survey data on the same relationships and to see, well, do 2 guys at least agree about what happened? So that's maybe a step lower in data quality from a biomarker, which is an external validation, but we can at least look at what 2 guys say about the same thing. Oh no, my little graphic guy. These were little guys. Imagine it was Wingding's font, which is apparently not on this computer. And so these were little guys, and the guy on the left was enrolled in the study, and then these were his 2 partners that he elicited in the survey. So our surveys, we have these really cool surveys where we basically do a partner-by-partner inventory. We say, tell us about your last 5 partners. You give them names, and then nicknames, and then it marches through your guys, and you start saying, okay, I met him in the park, and we had sex, and this, and we go through all sorts of questions about everything that's happened. A very quantitative partner inventory. And we do these a lot of different ways. Actually, for this study, it was up to 10 partners in the previous year that we did this for. For a subset of partners, men would actually refer them into the study, and chasing them and referring them into the studies was extremely challenging. And I'll talk about basically how some of this data, how the data contributed to the analysis. This is the table that outlines it, but it was a graphical marching through of otherwise complicated table. But imagine you have a typical egocentric survey where men just tell you about the guys in their world. That's the egocentric view of data. I just tell you about my partners. So my little guy here, study participant 67, said partner 1 is 22 years old and he was a casual partner. That's what you usually get out of your survey. But we don't know anything about partner 1 because he wasn't enrolled in our study. We don't know anything else. We can't validate that. Okay, so that's why we call that one-sided dyadic data. About 95% of the time you see dyadic data, it's one-sided. Okay, so like this is the most typical type of data that we get, is a one-sided report. Sometimes we get these other two types of reports, which we call them unidirectional and bidirectional two-sided. I'll explain what I mean by that. This is another type of thing that you might get. Partner 1 is, the guy on the left is enrolled, ID 67, and he says, the second guy in my survey, he's 24 years old. Sometime later, we enroll this guy, partner 2, and maybe he's ID 702. But he happens to be the guy that came out of the referral from the first guy at number 67. And he does this. He says, I'm 26 years old, so now we have a discrepancy in the ages, but maybe he'll tell us nothing about ID 67. Because what happens is in these surveys, the next guy comes in a few months. He may or may not actually tell us about the first guy in his survey because either they had sex too long ago, or for whatever reason he doesn't tell. He has to nominate the guy in his survey as someone to talk about. You have to be able to link backwards. So what often happens is you have a forward direction, and you get only certain things. You can only look at the validity of demographic data. Is basically what happens because. Right, the first guy says 24 years old, and the second guy says, no, I'm 26 years old, and we believe the second guy because it's actually himself. And so hopefully we believe him, and frankly what we always do is we check IDs, and we actually know we know what their birth date on their license or whatever is. And so with unidirectional forward data like this, you can always validate demographics, which is kind of cool, and I'll show you the demographic data. But the real holy grail is the next one, where the second guy tells you about the first guy, and then you have demographic data in two directions, and now they can describe the sex that they had together. So you need the reflexive going backwards to talk about risk behaviors. So this is the hardest data to get. It's really tough. And so what we have to do is basically we collect names and we do name-based probabilistic matching to figure out which of the guys this guy has to name this guy, and we have to match the names we use a cancer registry linkage deduplication program to actually do name matching and figure out which of the guys in the second survey was the first guy that came earlier in time. We also could have just asked, but we didn't do that.
I was going to ask you about this because I've done all these kinds of gymnastics, to try to match people, and we've done it forever. And Marjane and Ryan know because they've tried to do it too. And it's been really frustrating, difficult. And then I was talking to Brian Mustansky from Chicago last year, and he said, I just get the names.
Yep.
First name and last name, and they don't have a problem with their IRB with that. Do you do that now?
IRB does not care. So
all these years we've been trying to get...
Historically, they have cared. So it used to be tough, and if you have a thoughtful conversation about why this is important. So generally, IRBs don't like this kind of third-party hearsay type of stuff. So
you do collect full names, first and last names of the parties?
Not routine. In this study, we don't routinely do it unless we need it. And in this study, we needed it. And not only that, we also got permission to get contact info. So the first guy, 67, could have given us contact information about this guy. And we eventually got permission to directly approach this guy. So break out of this RDS snowball mode and directly go to this guy and try to recruit him. And it took a conversation, but they were okay with it in the end. So we got names, phone numbers, email address, the full Monty. So still very low yield. Still low yield.
Because the contact information didn't work.
You just chase people that aren't interested. People aren't interested. They move away. so many, like I was saying yesterday, like half of our sex partners are just transient one-off kind of encounters that you're just never going to recruit them. It's just really tough. So we had to do this name-based matching, which is still, even if you have the names, it's still not easy to go back. We also could have asked something like, is this partner the guy who referred you? We never did that. That would have been easier if we had just asked that.
Well, we did that, it still didn't work.
Oh. But it's really, really tough. So what happened is, we had a universe of like 1,400 dyads. Well, if you sum this up, we had 1,500 dyads. 62 qualify at this highest level of detail. So in a normal egocentric approach, you'd have all this one-sided data. And now we have a subset that are this like super duper in every direction. So the good news first is that demographics are really well reported. So this is actually this is good news for us. When someone says my partner is 22 or my partner is white or whatever it is, we had a really, really high agreement. So this is, the columns here are truth, and this is essentially what was said by the partner. So here, we have basically 97% or 96 out of 99 of black partners were reported as black, for example. And so we saw that Hispanic had the most confusion. So we have 78% of the 18, so these are low numbers. But so 14 out of the 18 were reported as Hispanic, but then we see some were called white, black, or other. So that's the most confusing. But generally it was pretty good, and age was very tight. So the median difference was 0 years, essentially. So men were very good at reporting age and race of partner. So that's the good news. So if we want to talk about risk due to intermixing of populations or for modeling studies, we can feel pretty good that we can accurately get from an initial guy the demographic profile of his partners. So that was the good news. The complicated news is the relationship stuff. And so this is a really, really busy table, and I'll just walk you through it. The rows are a whole bunch of attributes. Where they met, is he a main partner? Have you had sex with him more than once? Did you talk about HIV before you first had sex? Are you going to have sex with him again? Is this an ongoing relationship? That's kind of the way we ask this. Have you had anal intercourse in the previous year? Have you had unprotected anal intercourse in the previous year? Okay, so this is behaviors and attributes. And this is where you need the two-sided data. So this is small numbers. Pardon me, it's just really hard to get. We tried. And this is the proportion agreement. This P's, so the percent that say the same thing, whatever it is. They both say no, they both say yes. How many agree? And this is a kind of a kappa-like statistic, so chance-corrected agreement. It's not quite kappa because kappa needs to have a sidedness to it. You need to have rater A and rater B, but these are relationships. It's just man and man, and you can't compute the kappa statistic. So we made up this other thing, which is sort of like kappa. The basic idea here is that you have so-so agreement on everything. 70s and 80% agreement generally on all these features. So we have, most men will agree on anal intercourse, 94%, but only 78% agree on unprotected anal intercourse. So remember, our usual mode always is that outside of these studies is a very one-sided view. I had anal sex, I had unprotected anal sex. And we're seeing when you ask the partner, we have 78% agreement on UAI. So this is just going on in the background of all of our research probably, is we have just, this moderate agreement, at least when you compare it with what the other guy would have said. And so there's just this background misclassification that we have to deal with here. 70% agree on where they talked about HIV. Only 56% think they're in an ongoing, 56% agreement for whether you're in an ongoing relationship. Okay, so that's pretty, you can imagine what that means at the relationship level. One guy's like, no way, he's last week, and the other guy thinks he's my beau, and so it's all, that's, isn't it odd? And it's really tough. I mean, this is, it is a sitcom. And so what you see is that these, we didn't really have statistical significance for a lot of this because the numbers were sparse, but a lot of these were generally lower for black men. And this actually dovetails well with some of the work this paper that we did with Pamita, which is that black men seem to classify lower commitment relationships with higher titles. So, in the sense that basically lower commitment, much more casual relationships, black men will call a main partner. And we see a signal of that here, where 45% agreement on whether you're ever going to have sex again, compared to 69%.
On
Yeah.
that, and remembering that paper, since I don't remember all the details from it, we used the scale, and Brian, remember the good old partnership assessment scale? Well, Eli used that in here, and one of the things that Mark Johnson's working on this too is we compare, in that paper, differences by race ethnicity. And what I don't remember is, was there a difference in this, so the partnership assessment scale is supposed to capture all these different dimensions of the partnership, and was there a lower overall score for the partnerships by race in different groups, or was it that
It was, so what we did was we used the scale as just a piece. We also, we crossed that with more standard main casual stuff.
Right.
And so what happened was, what black men were calling main was rating lower on the partnership assessment scale. So lower strength relationships were being called main. And main, which is the CDC NHBS definition of like, he's your boyfriend, he's your committed above all others title. And so, but they were doing less committed things with those partners, essentially, is what that's the.
They did have a lower PAS overall.
Yep. And so, anyway, so what we see here, I mean, this is a limited sample size view, but we have generally lower agreement. What's important here, look at UAI in the previous year. 68% versus 90% agreement for black versus white men. So this is p-value 0.09, the data is sparse, do with what you want with it. But we see a signal here that two men two black MSM in a relationship seem to have less agreement on whether unprotected sex occurred. Now, what is that? Is that reflecting biases in our assessment? Is it a bias in the interview process? Is it something about the relationship? What is it? But this is at least a signal, in the absence of the biomarker data, this is a signal that our assessment of UAI probably ain't so good. We've looked at this a couple other ways. I don't think I have it here, because I'm going to talk about biomarkers in a moment. But in our incidence cohort, to the other study, we had all these infections, incident rectal STIs, incident HIV in men who were denying sex. Just these spontaneous, immaculate infections. And so you have other signals when you look in other ways, and here we're seeing it in just a dyadic agreement study. So it's tough. What we really need is a biomarker, desperately. The two main technologies that are in use for vaginal intercourse are PSA and Y chromosome. And the PSA work has been done by CDC, UNC, and Ohio State. It's some of the same folks that have kind of transferred between the institutions. And they basically have done various, so this is prostate-specific antigen, PSA. Women should not have it in their vaginas unless they're having sex with a man. Simple as that, okay? They don't have prostates. So if you find PSA in a specimen from a vaginal, if you find it in a vaginal swab, you know that women's been having sex with a man. Another assay is basically doing NAT testing for Y chromosome. So amplify Y chromosome, same idea. Women should not have any Y chromosome unless there was a man in there. So pretty great for vaginal intercourse. The problem is that there's no way to do. There's no assay really specific to men yet. So male sex, that is. So there's been about 7 or 8 papers using these in female populations, showing, lo and behold, differential classification by race, SES, and various HIV risk factors in the validity of unprotected vaginal intercourse. Okay, but we don't have this for male sex, right? We have 2 males, so we should detect, in theory, we should be able to detect Y chromosome, so that there goes that assay, potentially. And potentially PSA. There's been some preliminary work done in looking at PSA, even still in the rectum for men, and they just can't, even when you have known semen deposited in the rectum, the PSA assays fail. So that's not good. Jonathan Zentelman's group at Hopkins is the ones that do the Y chromosome assays. In theory, they have they haven't validated it really yet. They've done some laboratory spiking of samples type work to try to determine whether you can do basically looking for a variety in Y chromosomes. So basically, if you find more than 2 distinct Y chromosome signatures, then you would have non-self Y chromosome. And they, in theory, have this assay developed, but it hasn't actually been validated anywhere yet. And we started down this path and haven't finished it. So basically, there is no biomarker yet available for this, but we really need it. Or we need more clever agreement studies than what we have. So I'm going to run through this last one, which is awareness of HIV status. So this is another standard indicator that we use for everything that's full of flaws. So the awareness of HIV status. This is our paper on it up here. Right, it's an important indicator. It's the proportion of HIV infections that are diagnosed. Right, the denominator is HIV positive by a lab assay or by an actual biomarker test. The numerator reports a diagnosis. And so, it's an important indicator for two reasons. First of all, it's a standard indicator for monitoring the state of the US HIV epidemic, right? We want to know what proportion of infections are diagnosed. Key important indicator. The second piece is it's a really important marker for we use it in our risk framework, right? The more undiagnosed infection, the more inadvertent exposure to HIV is going on. All right, and also that we know that receiving an HIV diagnosis usually correlates with a subsequent reduction in risk behavior, right? So we use HIV diagnosis as an important way to understand transmission risk. So it's really, really important, right? And it's monitored by CDC in two important ways. So I often think about what CDC does because I hang out with them. And they used two different surveillance systems to talk about two slightly different concepts. The first one, which is the most standard one that we'll see out in the world, is done by basically through case surveillance, and they do a model-based undiagnosed. What they do is they say, what's the sum of HIV diagnoses in the United States? Then they do a lot of voodoo modeling to figure out the total number living with infection, and then you take the difference. Take the total with infection, subtract the sum of the case counts, and you get how many are undiagnosed. So it's model-based, and it's got some voodoo in it because they do a lot of that. There's a black box to figure out the total prevalence. And that's basically not awareness. It's not based on self-report. It's model-based, and it's undiagnosed. The other one comes from the National HIV Behavioral Surveillance System. That's awareness. And you say, NHBS does rapid testing, and then they ask people about their history of a positive test. This routinely shows very, very differential levels of HIV awareness by race, and the first one does not. So if you look at what CDC does at a case surveillance, model-based undiagnosed, shows only modestly different levels of race differences in diagnosis. Twofold difference by race in the NHBS. Completely, they're on two different floors of the same building, completely different answers to this issue. And the second one is complicated because NHBS will simultaneously report high differences in status awareness by self-report, and yet very, very high testing frequencies for black MSM, and those are sort of out of sync with each other. Right? And there's a lot of reasons why men might underreport. Mistrust of, this is highly sensitive information. Mistrust of healthcare providers. There's various HIV criminalization laws out there in the world, in the US South, stigma associated with HIV in general. Our questions might stink. I'm going to show you some of our questions. And then we think that sometimes men might misreport because they perceive the eligibility criteria for the study to be for positive or negative guys. So they think they're trying to say the right thing, essentially, to make it into the study. So that's another potential concern, is that people, what the eligibility criteria are, get out in the world, and people might say what it takes to get on the study. So we did the following. At our baseline visit for involvement, we took people who are unaware by self-report. They have a positive test result, but report no history. They report to our question, and it's a weird question, perhaps, but they basically are unaware according to our survey. We compare what they tell the counselor. So we have another opportunity. They have HIV counseling. They might record to the counselor a different answer. Some of our men have extremely low viral loads at the time of diagnosis, which would suggest ARVs or they're on the way up of a new infection, but very unlikely. And so that would suggest ARVs. We actually did ARV testing on stored serum because we actually were routinely banking. And then we also did a match with Georgia EHAR, so the case surveillance. We actually submitted the names of our participants to the state, which is IRB is okay with that. And the state, what they can do is they can't tell you back. The state will not say, yes, you submitted Joe is HIV positive, but they can tell you an aggregate. So you gave us 75 names, of which 60 show up in our database. And so we worked out an agreement where we can do an aggregate match back with the EHAR system. And look at this. So this is the difference by race. This is white men and this is black men by self-report, a twofold difference, exactly what NHBS shows. 32% unawareness versus 16. And once you start correcting for these other sources of data, you basically achieve unity here. Same levels of unawareness by race. When we compared with EHARs, we basically had 15 versus 13% unawareness. So these guys were all in the Georgia. So the difference from 32 to 15% was basically sitting in the state's registry of HIV cases. And similarly, we were able to reduce this somewhat by looking at who had a low viral load and who had detectable ARVs. Now, as you remember from before, I showed suppression and ARV usage data in black MSM, and it's not that high. So you can imagine that even looking for detectable ARVs would mean you're actually receiving treatment. And so to the extent that we have low access to treatment, we're not going to get it down as low as looking in surveillance, case surveillance. So basically, once you start bringing in biomarkers or external validations, again, we were able to basically show that this is the usual narrative is very differential levels of status awareness. Once you actually start correcting for stuff, the status awareness is essentially the same by race. And this is this is really the strongest evidence. If you just look in case surveillance, and there they are, unless they're out of state, and frankly, that didn't matter here. If they were out-of-state diagnoses, then that wouldn't have worked either. But these were in Georgia, sitting in Georgia surveillance.
So is this the paper that you published?
Mm-hmm.
So what was the reference?
This is an OFID. Travis Sanchez from our group is the first author.
What was it? What's this journal?
Open Forum Infectious Diseases. It's not that exotic. It's real. It's not Hindawi. It's real.
Is it on PubMed?
Yeah. Uh-huh.
Forum in infectious disease?
Mm-hmm.
It is?
No, it's like an actual, completely legit. It was a new journal, and I forgot.
Peer reviewed?
What?
It's peer reviewed?
Yes.
Open forum. It just sounds so. Yeah, it sounds so.
There's your friends publishing it.
They do?
Yeah.
But it's listed in PubMed.
Uh-huh.
What year was it?
A year or two ago? 2000, it's probably 2015. Look, there's real people you know on here, that have credibility. Anyway, the moral of the story is, again, the external validation proved really important here.
There are other journals out there.
And that there are other journals out there. We also actually did a qualitative Travis ran this part also, where we basically brought in 15 of these guys and said, what happened? 12 of them still endorsed their survey responses. Obviously, we didn't necessarily know, especially on the case match, because we got the results back in aggregate. We didn't necessarily know who was misreporting their status to us. But 12 out of 15 still endorsed the survey responses. 3 of them changed their tune. Only one of them really meaningfully changed the tune, which is that he said he knew his status, but was retested and did not receive the results of his last test. And I'll show you this, that the old way we asked the questions was about what was the result of your last HIV test. If somebody is positive but gets retested for whatever reason and knows they're positive, they may not go back and get their results. And so there's really some flaws in the questions that we learned. So I think in general we need to improve the comfort and assurances and confidentiality in how we ask this. And I'll show you we've changed the language in our survey to say it's okay to tell us this. We can improve the questions, and I'll show you that. And maybe this is just self-reported awareness is just this limited measure, and it's going to be what it is. So this is the original question from involvement. It was out of NHBS round 1. And this was the way that the question was originally asked, which is basically, have you ever had an HIV test? And then what was the result of your most recent test? So if you don't, it doesn't say were you ever diagnosed before that, and so if you were retested, or you may get confused and think this is a viral load test. So we've also had guys think that they have a low viral load, so now they're negative, or whatever it is. So there's some confusion. Like an HIV test doesn't say exactly what we're talking about, and it could be confused with a viral load test. And so we've changed our questions. This is how our question more or less, we have other questions, but this is basically how the equivalent thing is now done in Element. First of all, we add stuff around, hey, it's okay to tell us. It doesn't affect, your confidentiality is protected. You still get your incentive no matter what you say. And then also, you'll still receive and by the way, we're going to test you no matter what. Okay, so these three things, I think, and that's obviously when we explained this beforehand, but this hopefully will alleviate some of the sources of bias that were there earlier. And then also now we say, have you ever tested positive? Not what was the result of your last test. So we're learning, we're trying to learn. We're trying to get better. NHBS, I'll talk about them in a moment. You still have this one source of error where some people get diagnosed and never get told about it. Or that right? So that's still a source of error that we're not going to fix this way. NHBS changed. There are questions too. So what's been really nice about being in Atlanta is we actually get to bring them emerging results and get to change we get to work with NHBS and they've modified their questionnaires, which is great. And so they also now ask, have you ever tested positive for HIV? They don't do what was the result of your last test. So they're learning too, which is really great. Anyway, so we're at time, and so I just wanted to show again this result that I showed last time, which was from our agent-based model, which showed that in our agent-based model, this is the result of a lot of digestion of a lot of information. This axis is HIV prevalence for black MSM, and the y-axis is HIV prevalence for white MSM. This dot here is the observed prevalence in our cohort study. 44% for white MSM, for black MSM, and 13% for white MSM. And we fit our model to basically put every behavior and every piece of information that we observed on our guys into our model, and we were never able to hit the observed prevalences by race. We were able to recreate disparities, but we can never get prevalence for anyone quite to where it needed to be. Our white MSM prevalence always in many ways seems to be too high sometimes. We never can get black MSM prevalence up very high, except when we reverse misclassification of risk behaviors. So if you remember from the Millett work that we have black MSM reporting much less levels of sexual risk relative to white MSM, in a model, you can do this, magically impart onto black MSM the same risk behaviors as white MSM, then we were actually able to nail the 44% prevalence that's drawing a vertical line here. We were able to get black MSM prevalence up to observed levels by basically giving them not reduced risk behaviors. Now, whether that's truth or not, I don't know, but we have at least all this circumstantial evidence that there is underreporting across several things. So, basically, model-based probing lets us yield observed prevalence, and I think we're going to do future modeling work that lets us build the variation. Now that we have these validation data, we can actually build it into the model up front and look at scenarios across. We can look at the range in accuracy as the model inputs. All right, so what is the lessons learned here? We need to understand why this is going on. I mean, we have social postulation about why this is going on, but we need to really have probably more targeted studies about why MSM underreport their behaviors and why are black MSM particularly feeling uncomfortable in our studies. We need to adapt what we're doing. I think where we need to have a comfortable and open study environment. These are things that I'm sure we're all doing. We just need to do better. More formative work to understand how men want to be asked things in their research, which we try to do for every project. Comfortable research clinics, certificates of confidentiality, and communicating throughout all of our forms and our interactions and our surveys, communicating what we do with the data, why it's okay to tell us, why this work is important for the community. I think we need smart tools. So survey language that is friendly and explains what we're doing. Clever survey structures. I have some examples after this if we have time and people want to stick around. But we design, especially because our studies are often longitudinal, we design them longitudinally to get easier and not increase burden, because that's going to be another source of bad data. And then, of course, other modalities, SMS, apps, diary systems, and things that, again, reduce burden but get good data, Biomarkers and indirect methods, like the agreement studies and so forth. So we need just more of this. I mean, we just need more biomarkers. And then, of course, we can also, on the other side of things, adjust for biases in our analyses. So that could be the agent-based models where we say, okay, well, what if the reporting was actually this? Run it up and then see what you get. And the other piece is I'm doing this, frankly, in every modeling, standard statistical regression model that I do now, is just building in sensitivity analyses and just admitting your fallacy, even in these regression models, and saying, look, we know there's a range. This is what we observed, but there's really a range of possible results. And now that, imagine if you start, the more of this validation data we get, the more we can at least put in sensitivity analyses to show more truthfully the range of results. So, my thoughts. Anyway, I think we're at. Yeah. Sorry.
I think we're out of time, but I think what we could do is we could have some questions, but also we have a small conference room upstairs. If
Okay.
people wanted an opportunity to talk a little bit more in depth with Eli, they could
Yeah.
meet with him upstairs in the conference room if you have a little time.
Sure.
Okay. So thanks, everyone.
Thanks.
Could you